I'm Dr Michael Lawless, Clinical Associate Professor at the University of Sydney at the discipline of ophthalmology and also ophthalmic surgeon at Vision Eye Institute in both Chatswood and Bondi Junction. This topic is dry eye. Now, traditionally that's a really dreary topic, even for ophthalmologists, but it is important and it's changing and it's common and it affects a lot of your patients, particularly older patients. When people think of dry eye, generally they'd think, well, you know, they're just not producing enough tears. The lacrimal glands aren't producing enough. And that used to be the thought. Even 10 to 15 years ago, people thought, well, that's what dry eye is. It's Sjogren's disease, it's other conditions where the tear production is not good enough. Well, what's been established now is that inflammation is key. And it's inflammation in the oil glands, those meibomium glands that give you tarsal cysts and things like that. Inflammation in the oil glands is 7 times more likely to cause dry eye than just a dry eye based on lack of lacrimal production. So the thinking on what causes dry eye has changed over the last 10 or 15 years. And that's a fundamental thing, because the other thing that has been established is that dry eye disease is progressive and it's largely preventable in most people. And what you don't want as a general practitioner or as a human being is to have this progression of a condition which is largely preventable and ending up at 75 or 80 with really miserable red, sore eyes where they're putting a few teardrops in and it's unfixable at that stage. What you need to do is pick up early those patients in their 40s and 50s and 60s who have dry eye symptoms. There's different ways you can elicit that. And generally, people with dry eye have symptoms. They describe itchiness, burning, discomfort, particularly when they wake in the mornings, but sometimes at the end of the day, depending on the environmental circumstances. And the thing to work out is the dryness due to the lack of tears, or is it due to inflammation? And you get a lot of information just by looking at the patient. Look at their skin, for example. If they have a rosacea type appearance, that telangiectatic vessels on the cheeks and around the lid margins, they're much more likely to have the inflammatory form than any underlying aqueous lack of production. And so simple things like that, observing the patient generally. You can look at the lid margins in particular. You don't need much to do that. You just need a bright light and some magnification. And inflammation along just where the lashes are, the meibomium glands, if there's inflammation there, that's the most common cause of a disturbed tear production. And so there's some simple external things you can do. You can start by saying, well, okay, if this is an inflammatory condition, we've got to treat the patient from the inside and treat them from the outside. And by that I mean, from the inside, the thing that makes a big difference are omega-3s, fish oil. And fish oil is definitely shown to have a positive effect on the quality of tears by dealing with lid margin inflammation. And if you just 1 capsule a day for a 3-month trial in a patient, if they're suitable to take oral fish oil, can be a key decider or key determinant as to how they're going to respond. You can also use a simple thing like what's called Sterilid cleanser, available from a pharmacist over the counter, and it's a method, it's a foam which is used at night, and it helps the patient sort of clean the lid margins and open up those oil glands, so it deals with the root cause of the dryness. Simple things like that. Sometimes oral doxycycline, oral erythromycin is useful for inflammation as well. Treat them from the inside with those oral medications and from the outside with that Sterilid cleanser, and heat as well. Heat you can use just as a simple warmed washer, or you can get little heat packs which you heat up in the microwave and place on the surface of the eye. Those things really get those meibomium glands working. The reason it matters to treat dry eye is that if you let it progress, it leads to chronic scarring and drop out of these meibomium glands, and they never get back to normal. Whereas if you get them early, you can deal with the inflammation, you can get those meibomium glands working, and you have a really happy, comfortable patient, and they haven't progressed to disease which is then largely unfixable. You won't have access to sophisticated diagnostic technology, but you'll get a sense of whether that patient has dry eye, and take it seriously would be my message. This is largely a preventable disease, can make a huge impact on a patient's quality of life if they end up at 70 or 80 with comfortable eyes, not dependent on drops all the time, and you can make a big difference in that patient's life.